Well, dear Mr. Chairman, thank you very much. Dear colleagues, dear Wolfram, thanks for inviting me, leaving me alone with the contraposition in an audience, I think mainly consisting of cardiologists, but fair enough. So let's start with my conflicts of interest. I'm talking about oral anticoagulation, so you should know that there is a conflict of interest. And yes, of course, all of you know that there is a high prevalence of PFO, and at least 1 out of 4 in this room has a PFO, and I think the vast majority of you will never get to know it. And that's why it's very often an incidental finding in our patients with stroke, irrespective of the fact that there's a higher prevalence of younger stroke patients with PFO, as said before. So there is a role for PFO, and you've seen a thrombus like this in the previous presentation, but I think all of you have seen such a thrombus probably once or never in your life. So that's a real seldom finding. And usually you find a PFO, and in the vast majority of cases, this is not related to the stroke etiology. But if you close the PFO, then you might have an embolization of the device. This is a pretty seldom complication, to be honest, but it's reported in the REDUCE trial, one of the newer randomized controlled trials, in up to 0.7%, so keep that in mind. Or you might have a thrombus, as indicated on this slide, and this happens to 0.4 to 0.5% in the new randomized controlled trials, REDUCE and CLOSE. So this is a complication, and you have to think about it before you close the PFO. Well, these are the old randomized controlled trials published in 2012, 2013, as said before, but I wouldn't say they've been inconclusive, they've just been negative. Main thing, there was lots of residual shunts, probably due to the Starflex device, which is no longer on the market. There have been a substantial rate of atrial fibrillation after the intervention, and there was just a trend in the RESPECT PFO trial demonstrating that there might be a benefit in selected patients with a cryptogenic stroke aged 60 years or younger. And the RESPECT PFO trial was first published after a follow-up of 2.1 years, and again published with a follow-up of more than 5 years. And as you can see, there was a significant benefit at the end, but unfortunately, and this is a main limitation of this long-term analysis, there was a dropout rate of about 20% in the PFO closure arm, and every third patient in the medical therapy arm left the study before the end in the publication of the data. This is a major drawback, and that's not the evidence we need, but as said before, there is new evidence, and that's pretty good that we got it. There have been 3 trials, and you have heard about the Korean trial, including the 120 patients. This is special because this trial enrolled patients up to the age of 80, but not focusing on those patients aged 60 to 80. And the other trials, with more than 660 patients, the REDUCE trial and the CLOSE trial, they included patients up until the age of 60 after cryptogenic stroke. So let's focus on these 2 trials, and I think you have seen this slide. So the first message is that the overall stroke recurrence rate is rather low. And the second message, yes, there is a benefit, but this is just a modest benefit in an overall low stroke rate. And the next thing is that the trial has 3 arms, as you can see, and we're just discussing the data regarding the device, which was chosen by the investigator, and that's a big achievement because this was an industry-independent trial, but that's the only one. And the data regarding the oral anticoagulation versus the device have not been published in detail. But the main thing is, if that ends up with a number needed to treat between 40 to 50 to reduce a stroke, and if we now focus on disabling strokes, and there's a publication in this data are depicted here, overall we got 14 events in the antiplatelet group, but there was just 1 disabling stroke. So the number needed to treat to prevent a disabling stroke is much higher than 40 to 50. So keep that in mind, and you have to outweigh these evidence against the complication rate. So the REDUCE trial, industry sponsored, said before, pretty similar picture. there have been lower events, a lower event rate in the antiplatelet group. But if there is a tremendous effect, I think all of you would expect that even MRI-detected silent strokes should be reduced after the procedure. But just share the data with you. As you can see in here, there was no difference regarding MRI-detected silent brain infarctions between both study groups. So I think this is the thing you should also think about, because a main limitation of all the trials mentioned is that they were unblinded. All the patients knew that they got PFO closure. The thing about the trials focusing on PFO and migraine, there have been some reports just demonstrating that if you close a PFO, there is a reduction in migraine. And you might argue that this is due to aspirin, because aspirin is a part of has a thrombolytic efficacy in migraine patients. But coming back to the issue, unblinded trials. So if the patient was convinced that there was no stroke after closure of the PFO, he might probably missed a few strokes. And in the control group, the patients might have went to the hospital with a comparatively low stroke. So that's one of the issues. And next thing, yes, of course, the meta-analysis, and there are a bunch of them, just demonstrating that there is efficacy in those patients aged younger than 60 years. But on the other hand, there is a 4 to 5 times higher risk of atrial fibrillation in this cohort. And yes, of course, there was no systematic screening, so probably the risk was even higher. And yes, there have been statements that it was just a transient phenomenon. But to be honest, nobody knows it. Just think about post-operative atrial fibrillation, which can be found in up to 30% of all the patients. So we are not sure whether this increases the further stroke risk. But we should take care of that issue, and I think it's totally unclear how long we should monitor after a procedure, because it was not done systematically in the aforementioned randomized controlled trials. So I think there are a bunch of open questions, and the first question is, are the results even eligible for those patients with a TIA? And all of these patients have been excluded from the randomized trials, so we don't have any data in this regard. Second question, are the results eligible for those patients aged older than 60 years? And to be honest, it was mentioned that it was a European position paper just stating that up to 65 years of age you should close a PFO. I don't know where they get the data from 60 to 65 years. To my mind, we don't have the data yet. So there's a clear cut, and this is 60 years of age. Next question, is PFO closure beneficial in those patients with a rather low shunt volume and those patients with an atrial septum aneurysm? And another question is, what about material fatigue? Think about implanting devices in those patients aged 30 to 40 years. What will happen in 60 years afterwards? Nobody knows it so far. How long should we monitor for atrial fibrillation before we close it and after closure? And the next thing is, what duration of antiplatelets should we have after closure? So the position paper recommends dual antiplatelet for up to 6 months and monotherapy with antiplatelet for up to 5 years. So nobody is sure about this. And the last question said before, is PFO closure in cryptogenic stroke superior to anticoagulation? And yes, this is a sub-analysis of the Navigate ESC trial, and there is first meta-analysis of 3 trials demonstrating that oral anticoagulation, with all the drawbacks mentioned before, might be superior to antiplatelet therapy. And this makes sense in a way that you think that paradoxical embolism is probably due to venous thrombosis. So treat with oral anticoagulation, and I think we might need new trials to focus on that issue. And so this is the summary. Yes, there is evidence, but from non-randomized trials, but there is a benefit only for patients with cryptogenic stroke aged 60 years and younger, and there is a number needed to treat which is not that low. And yes, of course, feasibility is very good, but I think the complication rate should not be neglected. And my personal opinion is that it is an individual decision affording a detailed interdisciplinary diagnostic workup and, of course, a patient involvement. Thank you very much.